said she's a singer and a songwriter and a theater performer and a mentor to many of us. She's a family person, my boss, and an amazing professor. And she's sitting right next to me, and we are social distancing safely.
With my teacup.
With our scarves on. So I just wanted to do a line of business and let everybody know the format for today's session. We've removed attendees' names for anonymity. Everyone's microphones will be muted. The meeting is being recorded, and it's going to be posted on our Wisdom Study YouTube channel afterward. We're going to email you all a short post-survey meeting, post-meeting survey for your feedback afterward. And we also are taking incoming questions to us through the chat function on your Zoom screen. So we'll be channeling those to Dr. Esserman. We're also going to be hosting a second session in mid-May due to the high demand and also the Zoom limitations. So fear not if you are unable to join or if you want to share this with other people. We're going to have a second session. Thanks. So during the call, we're going to review some slides that contain important issues that women are facing during the shelter in place, and then we're also going to review your questions.
Okay, everybody. I hope everyone can hear, and Sarah, you can hear us, right?
Yep, sure can. Sounds good on this end.
Okay, good. All right, just making sure. At some point, I'm sure our faces will eventually show up, but you never know. So we're just going to keep talking through things. So I think a lot of people, you know, if there are people here who have cancer or in the middle of treatment or know people who are being treated, I thought it would just be useful to go through each one of these situations in general. And for the question and answer, I'm going to do my best to try and answer questions. And of course, we want to keep it general. I can't make it too specific to any one person because, you know, it's hard to do that over the phone. But we're just trying to get the general principles out so that, you know, people don't have to feel quite so anxious about this. You know, it's true that during this time with the COVID pandemic, your treatment and screening schedule may change. But your care team will reschedule or delay treatment only when it's safe to do so, because we can still take care of people, especially in California. We're so lucky that our healthcare systems are not overwhelmed and that we really are able to deliver the care that people need in a timely way. Now, that said, we can also do things to reduce the need to come in early or get procedures during the highest risk time. It looks like by the middle of June, a lot of places will have resumed their normal screening schedules. So that will be a total of about a 3-month delay, which really is okay. You know, if you're in the middle of chemotherapy treatments or you have someone you know is getting treated, reassure them that it's okay they should continue and it's okay to continue. Physicians may, you know, give more growth factor support or things that really make sure that people keep their blood counts up. But or they may switch to regimens. We have choices, and sometimes you can switch from a every week regimen to an every 3-week regimen. There are pros and cons to doing it in general. We know these are safe. And as always, you know, you can talk all that through with your physician. One of the things that I think is challenging is that caregivers are not able to come into the office with a person who's getting treated, or if they're needing surgery. And that has actually, I think, been one of the most challenging of this whole epidemic, where people feel alone. Now, people are trying to use technology to make that better and making it possible to video visit from right from the phone or video and make sure that people can be present. We do this anyway, and now the technology is better to be able to do that. For people who have finished their systemic treatments or their surgery and they're waiting for radiation, your radiation oncologist can work with you to prioritize when to start. You know, sometimes we'll start at 4 weeks, 8 weeks, or 12 weeks. there really isn't any data that makes any difference. And depending on your situation, there may be opportunities to really safely delay an extra 4 weeks or so, or 5 weeks. I think additionally, it's very important that, we've worked really hard to identify those cancers that are sufficiently low risk that radiation doesn't really contribute much. There have actually been 3 randomized trials for especially postmenopausal women who have hormone-positive tumors under 2 or 3 centimeters that radiation certainly doesn't make a difference in whether you live or die. And these are guidelines that we at UCSF have been using now for years on the basis of large randomized important trials that just have taken a long time to adopt. So one of the silver linings of this epidemic is it's forcing people to really look at the data carefully and say, do we absolutely have to do this? Is this really benefiting people? And sort of, sometimes, we fall into the trap of thinking that more is better when more isn't necessarily better, it's just more. And sometimes more is worse. So if it's not bringing much value, you're going to get the side effects and not the benefit. So I think these are just important opportunities to think about what matters and how much it matters. And then you can think about whether, those trade-offs make sense. That's of course true for making decisions about chemotherapy. Remember, there once was a time when anyone who had a tumor that was a centimeter or greater got chemotherapy. Now we know it's all about biology, and we don't do it unless there's a molecular tool to tell us that you have high risk biology, or for early recurrence, where we know that chemotherapy is going to make a difference. So for mammogram low risk or mammogram ultra low risk, certainly we don't need to do much. And for oncotype high risk, we wouldn't do much. Not that isn't the highest risk, we wouldn't give chemotherapy. So these are all changes that have happened over the last decade that have made a huge difference in our ability to tailor treatment. So one of the great things is one of the things that we've been doing for years also is when someone's first diagnosed, you don't have to start with surgery. Now, why was it that we closed down the ORs and stopped all elective surgery, tried to make this change? And part of the reason was nobody knew exactly how the pandemic was going to unfold. As you can see, in certain areas of the country, like New York, it really caused a huge toll on healthcare resources. And the reason why people are doing so badly is because when you overwhelm the healthcare system, there isn't the capacity or the ability to take good care of people who are very sick or the people who have non-COVID conditions. We are lucky in California that we got our shelter in place in time and did not overwhelm our systems. I think Dr. Rutherford has estimated that in the Bay Area alone, we may have saved 44,000 lives. So you may be feeling bad about sitting home, but think of all the people's lives you have saved. That should make you feel all warm and fuzzy inside. And I think as well, people wanted to make sure that they had enough time to get all the right personal protective equipment in place, to get systems in place, to do testing, to figure out how to take good care of people. We are now taking people back to the operating room, but now we have testing in place. We didn't have that a month ago. So, I'm really amazed at how well UCSF has responded to this crisis. And I feel like all of the systems are now in place for us to then open back up safely for people, and people can have a lot of confidence about that. So what we do normally, a lot of the things that we do normally have now suddenly become mainstream ideas for the COVID times. And that is when someone comes in with a big cancer, we don't start with surgery first because we think it's more important to understand how the systemic therapies are going to make a difference in terms of response. So if we start with either chemotherapy if you need it or hormone therapy if you need it, we get to see how you respond, and that can make your subsequent treatment less, we can do less appropriately or maybe more if we need to. And we can adjust treatment based on response, which is good. And as well, it gives us 3 to 6 months where you don't have to come into the operating room, and we have plenty of time to get prepared and ready. Now, for precancerous lesions like stage 0, we have an active surveillance program, and we've learned that it's perfectly safe to give people a 3-month window for observation and figure out which way to go, because we're doing those things for invasive cancer anyway. So there's lots of opportunities to safely change the order of care, which we actually believe is better. Now, what about if you've been told you have an abnormal mammogram or some abnormal imaging? The first thing to find out is, well, how abnormal is it? You know, and this is actually something you should be asking anyway, even when it's not COVID. Maybe if it's a very low risk lesion, you don't have to get a biopsy or you don't have to follow up on it. So are people worried that you have invasive cancer? Do they think it might just be in situ cancer? You can sometimes have an option to wait 6 months and see if anything changes before you get a biopsy. That's an option in non-COVID times, and particularly in COVID times. If there is a finding that's very suspicious for cancer, especially if it's larger, you should go ahead and get a biopsy. This can still be evaluated. And that's true if you have a new mass, regardless of whether you've had a normal mammogram recently. That's something you have to bring to your physician's attention. Again, your first step might be a video visit, but you can't do a biopsy and an imaging exam over the phone. So if you have a new lump that you think is different and this changed, I always say women know their bodies best. If there's something really new that's different, bring it up to your physician and know that we're still here to take care of you. I haven't gone anywhere. Now, people ask about what about delays of scheduling of mammograms and imaging appointments. If you're due for a routine cancer screening, you know, wait for this shelter in place. And again, we believe, you know, at UCSF that mid-June is the time to resume. That will have been a total of 3 months. A lot of times people have been told, oh, you might have had some little something on on a CT scan or something that incidentally was found. Most of those things can be screened less anyway. So 3 months is not going to change your outcome. It's okay. And even if you find out, say you've got a genetic test that tells you you're at high risk, well, we know that maybe that's increased your risk. You can still get a consult. All that can be done over the phone, and we can start scheduling the screening tests in June if you need it. So I'm just going to close with a few thoughts, and then I'll go to everybody's questions. And, you know, if you can, go outside. Don't forget to wear your mask. Stay 6 feet away from everybody. I hate to give this advice since I never follow it myself. Get enough sleep, but I do acknowledge that that's a good thing to do. You know, everyone's worried about what vitamins should I take. The best thing you can do is eat healthy foods. We are so lucky in California to be surrounded by farmers markets that are still open and, you know, really great fruits and vegetables. And so one of my friends, chefs and the nutritionists always say, eat the colors of the rainbow. So that's good. And take time for your mental health. It's a good time to reinvest in old hobbies or things that you love to do, and find something every day that brings you joy. And, you know, resilience is the key to getting through this, but it's also the key to getting through life. So just when you think that everything is bad, you can also think about, well, I mean, everybody is suffering in that same way. Everybody's life has been turned upside down by this. But, you know, everyone has to adjust and everyone has to adapt, whether it's because if you get a diagnosis of cancer, anything goes wrong. The key to life is being able to figure out how you're going to adapt and how to use this pandemic to find some silver lining. You know, maybe it's because you're finally going to get someone in your family to clean out the garage or reclaim your office or throw a bunch of things out that you should have thrown out a long time ago. You know, find some project or find something that makes you think, wow, this is a silver lining. I'm sure everybody can find that. And focus on the fact that you're not living in Queens and in an ICU with COVID. That is actually a good thing. All right, so one quick thing about the Wisdom Study. Many of you who are on the line, I know, are part of the Wisdom Study. That stands for Women Informed to Screen Depending on Measures of Risk. And we know that one size, as you know, one size doesn't fit all for breast cancer treatment. We've just been talking about that. And it may be that one size doesn't fit all for breast cancer screening. So we're testing, you know, whether screening every year starting at 40 for everybody, maybe it's better to personalize screening based on people's risk. more for the people who really are at high risk, which is a smaller group, but maybe less for the people that are at lower risk, and so they don't get all the negative consequences of screening. And the only way we find that out is to join the Wisdom Study. So if you're already in the Wisdom Study, this is a great time to find 5 other people and tell them to join the Wisdom Study. If you did that, we would be very successful in meeting and making sure this study gets completed and we can answer this question. We need everybody. This is our study. This is a study by women, for women, and a few really great men too. But this is, but we really need everyone to help us answer this question, because that's the only way to move forward in a good way. And we think there's going to be so much good that comes out of this study. So tell everybody you know about it, and it's just easy. You just can go to wisdomstudy.org and go and sign up. You don't have to go in for a screening exam to sign up, and you can, depending on which arm you're in, you know, we do genetic testing in the people in the personalized arm, and that takes time, so that can be cooking while you're waiting. And for those of you who are actually in the study, don't forget, if you haven't filled out your surveys, that is a great thing to do. So that's a wonderful thing to make sure that you're filling in. The study's only as good as our follow-up. So if everyone who's in the study fills in their follow-up forms and lets us know how they're doing, the study can be successful. Without your help and without your full participation, the study will not be successful. So let's make sure that all this work is for, that we really finish the job and get to a great result, which is an answer going forward. Okay, so I'm going to stop sharing and hope I'm going to stop share and see if we can figure out if our video is working. It's still not working. Sarah, you still haven't figured out how to get the video working?
Sarah got dropped from the call. She's working her way back in.
All right.
Technology.
Oh yeah. So
We can start with the questions that we have.
okay, we'll start with some of the questions that we have. It's right here. Okay, so one of the questions that I was asked is, for those who've been informed that we have dense breasts, is annual mammograms the standard of care, or should we be getting routine MRIs? So that's an excellent question, and that is actually part of what we're trying to ask. And so part of the problem is that we think that you have to have more than just dense breasts. We think that you have to have dense breasts and be in a high-risk group. While it's true that having dense breast tissue increases your risk, we don't think that MRI screening should be used unless you really have a substantial risk, because MRI actually has a lot of false positives. And that can also increase a lot of anxiety, and people get a lot of unnecessary biopsies. And so we try and reserve that test for the people who are really going to benefit most. And it turns out that half of women have dense breast tissue, the way we define it today. So there's a scale of A through D. A means the breasts are very fatty. 2 means there's some scattered stuff in the breast tissue. 3, they use the word heterogeneously, so it looks like a patchy density. And then very dense, which is kind of really the tissue's just much more solid. And so what we find is that only about 15% of people have that highest risk density. For the most part, people in that BI-RADS density C, we do not believe that there's a reason that for that alone to justify getting an MRI. And if you are in a high-risk group, in addition to having very dense breasts, then we think an MRI is necessary. And that's part of what we're trying to study in the Wisdom study. One of the other things that we're trying to look at is, are there faster, better ways? You know, we're trying to work together to try and build a study to be able to look at some some new tools, a very shortened MRI, or maybe even an MRI that doesn't require an IV contrast material, because we know women would love that, where you don't have to have either compression or an IV. That's called diffusion weighted imaging. It's not ready for the prime time yet, but we're trying to get it there because we know that would be a great thing. Okay, second question is, I'm BRCA2 positive, as are 2 of my 3 daughters, and they're in their 30s. And normally they would have an annual MRI and mammogram, but what about now? And so by early July, I would say that those screening exams can resume. I think during this whole crisis, a delay of 3 months is really fine for the people at highest risk. I think by mid-June, July, all of those screening exams will continue. I know at our institution at UCSF, we're going to resume our normal schedule in mid-June. Okay, now, again, another question about dense breasts for someone who's 73 and wondering what to do without any history of cancer. And we do not think that ultrasound is really the right study to do. If you're really at high risk, then an MRI is important, but again, it depends on what the other risk factors are that you might have without family history. So it's likely that if you're 73, that you would not necessarily be someone that I would suggest would get an MRI without family history and without having a personal history at that age. Again, I would think that would make a difference. But again, I think it's also important that people remember that, you know, almost 50% of women find their cancers themselves. So just because you're getting a screening mammogram doesn't mean you shouldn't be aware of your body. And we know that there's no benefit to an in-depth examination and looking for every last little bump on the breast. That just drives everybody crazy. But what I find is if you're just aware of what your breast tissue feels like, if it's lumpy, it's lumpy. Just get familiar and know your body, because if you find a change, that's what you should bring to attention. And remember, the fastest growing cancers will often show up between screening mammograms. We call those interval cancers. And screening does not fix that. Those are just fast growing cancers. And they're, you know, that's something that people need to know. If you find something like that, you got to bring it to attention and not delay because you'd had a mammogram 6 months earlier. Okay. So another question is, how do we know when women can stop? And I think that's an important question because, you know, do people have to get mammograms for their whole lives till they're 90? So there really isn't great data for continuing to screen beyond the age of 74. And one of the things that we are trying to ask in the wisdom study is, once you hit 74, again, if you have lots of other health conditions, the chance that mammography would make any difference is very small, because you have, you know, if you have a lot of serious health conditions, your chance of living more than 10 years is fairly low, and it's not going to help you. If you're very healthy, it really depends on your risk. If you have extremely low risk, it probably isn't going to be of much value. These are the questions that we can ask. I think most people continue mammograms, you know, often until 80, 85, and we don't know that that's really of a lot of value. And I think this is important for us to be able to ask, and that's one of the things that we're trying to do with the wisdom study. You know, I don't think everybody loves getting their mammograms, and, you know, but they're happy to do it if it's good for them and it's safe. So that's one of the questions, and we think that an alternative to just getting screened, everyone getting the screen the same, that we should really tailor our recommendations to each person based on their own risk. Another question was about intermittent pain. Breast pain is so incredibly common. Very rarely can be associated with the cancer, and it's always something that's good to bring up. That's something that, again, you can have a video visit to discuss, and we can often sort out what that is on the phone. But I think that I think one of the things that we can do is sort out whether there's something that's really new and different that you need to come in for. As I said, by July, you should call the place where you normally get screened. As I said, by mid-June, UCSF will be resuming all its normal schedule. So I'm going to look also. I'm looking to see. And so we actually, most places are still open. Our breast program, we are actually, talking to people. We're doing a lot of our first visits by video, which actually is very convenient, especially for people who live far. It's really, I think, easy and good for people to be able to get on the phone and talk about, do their initial evaluation by video visit. And it's just like sitting across the table. And then you can arrange for somebody to come in and have an exam. And I think here's the silver lining about this COVID time is it actually slows down a little bit. Even for people with highest risk cancers, we often give people 4 to 6 weeks if they want to harvest eggs. So for a young woman who wants to, preserve her fertility, she might harvest eggs and make sure that she can put some away for later. And that can take an extra 3 or 4 weeks. And we have found that does not increase somebody's risk, because once you start treatment, it's all about getting the right treatment and getting that treatment right. So a delay of 3 or 4 weeks makes no difference. And I think the good thing about slowing down is it makes sure that you've really thought about what your options are and realizing that you do have options. So I think that's, I've always said cancer is not an emergency. It's an emergency because you know about it. So it's really important for people to feel supported and feel like they have the time and ability to consider their options and maybe consult with a couple of different people to find out, if they have different approaches or if there really isn't, if they're not happy with their options, although, we certainly don't have a perfect answer. I would say the other thing that I would also say that I think it's really, really important for us to continue doing research. The clinical trials that we conduct are tomorrow's treatments that we make available today. And our whole goal is to try and make treatment better. And so we feel like the trials really provide that opportunity for us to continue to learn and find better options. So one of the questions I just got was how many people are already in the Wisdom study? We actually already have almost 27,000 people signed up for the Wisdom study, which is great. We'd like to see that number be 60 or 70,000, or maybe even 100,000. That would be awesome. Another question someone asked was, how do you define high risk? So we sort of look at the distribution of women in every age group. The risk scores change. So we look at a combination of things. Your exposures when you started, your own internal hormone exposures, like when did you start your period? When did you have you had children? What was your age of your first child? And then then to really be able to ask about family history and breast density, and whether you've had a biopsy in the past and whether that biopsy showed anything abnormal. And as well, on the personalized arm, we can also look at the genetics, whether you've had a gene mutation. And there are some small genes that we look at. There's several hundred genes that are slightly different from person to person, and we can sort of look at the group of these polygenic risk, or many poly meaning many genes, like polyjuice potion from Harry Potter. So poly means many genes, put together. that can actually move your risk up or down some. And that's one of the things that we're testing in the wisdom study too, is that when you put all that together, people in a really high risk group really are people who have the range of 25% lifetime risk. Every woman has risk. You know, the average person walking around has about a 12 or 13% chance of getting breast cancer in their lifetime. So that's average. So we found that people, you know, once you get to double that risk, that's the time when people start to think, well, maybe it would be worth my while to think about doing something to reduce my risk. And there are many things you can do to try and reduce your risk. You know, some of them include lifestyle changes, getting exercise, trying to get exercise, 40 minutes of exercise 4 or 5 times a week, keeping your alcohol intake under 3 to 5 glasses of wine a week, trying to, you know, really maintain your body weight in a more normal range. Those are things, by the way, that are good for you no matter what. You know, eating a more plant-based diet, these are things that are good for you. Sometimes they're just hard to do. That's good for you. But there are also things that we can do, which are medicines for women who are still having their periods. Medicine like tamoxifen actually can drop your risk in half. F-atypia, maybe even 3/4. And you wouldn't take it if you didn't have risk, but you wouldn't take it if you didn't have risk. But if you do, if you can drop your risk in half and you don't have side effects, and actually it turns out that most people don't have side effects. So I always say to people, there are many options for reducing your risk. It's like taking a statin. If you have, you know, an increased risk of stroke or heart attacks in your family, you can drop your risk in half. These are really, really important to do. Not if you have a little bit of risk, but you have a lot of risk, that can help you quite a bit. So it's worth thinking about. And I always tell people, don't make a decision. Start by trying it for a month, finding out how you yourself respond to the medicine, and you can make a decision about whether you want to do that. I have another question here from someone asking about intermittent nipple sensitivity. That is very, very common and almost never associated with breast cancer. But if it's something that's brand new or different, you can always talk to your physician about it. I'm looking at some of the other questions. So another question was, can your breast density change over time? Absolutely is the question, is the answer to that. So what we want to be able to say is, you know, can we So density, as you get older, usually your breast density gets less, but not always. Not surprisingly, when you go through menopause, your breast density gets less. If you're using postmenopausal hormone replacement therapy, your breast density can go up. And we notice also that if you're taking a medicine like tamoxifen or an aromatase inhibitor or something for prevention, or even if you're on, if you're using it as a cancer treatment, it often drops your density. And that's one of the ways in which we know it's working. So that's actually one of the tests that we're trying to develop to really help people understand, I think that's one of the most important things we can do. I think most women want some kind of assurance that if they're taking something that it works, as a blood pressure medication. If your blood pressure is high, you want to know your blood pressure is going down. So if you're taking something to reduce your risk, you'd like to have some indicator that it's working, and breast density is one of those things. And also, if you're in a group that's getting breast MRs, we can also look at the background, how bright the background is in the breast and how much difference that makes. Another question was whether color testing is still happening during this time, and the answer to that is absolutely. We are definitely still testing, so this is a great time to sign up if you haven't signed up for the wisdom study. If you are assigned to the personalized arm, by choice or by, if you're randomized to it, you will be able to get your testing. Someone asked about whether there was anything on the horizon for genetic engineering or CRISPR to repair BRCA defects. That's a really exciting area, and people are working on it. So I would say it's on the horizon. I won't tell you whether that's the 5 or 10-year horizon, but it's hard because you have to change every cell. I think there's some really interesting questions, which is like, people who are BRCA, every breast cell doesn't develop cancer. So what can we do to augment it? And there's some really interesting ideas, some interesting research that's going on. So another question was these SNPs, or what we call these single nucleotide polymorphisms, or the things that sort of roll up to be polygenic risk. They have been added to personal profiles. I think some of the testing, it makes it really hard to tell what's what. But as that changes, we just keep adding. So we're using the best risk tools at the time. So our risk profile has changed like every 6 to 12 months since we've started, and we just, as things emerge and get better, we keep changing it. And so more SNPs doesn't mean higher risk. It just means there's more genes to consider in determining that risk, and it makes a little bit of difference, but not a lot of difference. Someone asked a question about being in the study, which was, and thank you for being in the study, but if they say, I'm in the study, but I'm not sure what I need to do next, and how can I find out? And the answer to that is call or email us. We're always happy to help. There's a little button on the Wisdom, if you go to wisdomstudy.org and you look for the button to get help or get your questions answered, you can just send us a question and we'll call you right back. Someone else asked a question, said, who can join the Wisdom Study, and is there an age requirement? There is. You have to be between 40 and 74. You can't have had breast cancer. And you can actually now join from anywhere in the country. Someone asked about, again, what polymorphism is. And so again, these are just, again, these small little genes that vary a little bit from person to person. There's, hundreds of thousands and millions of these, but there have been about 300 or so that have been identified that if there are particular changes, they're associated with a higher or lower risk for breast cancer. And so together we analyze those as polygenic risk. So that means it's not a mutation that you've inherited, it's the small changes that you've had it. Someone else said that her mother turned out to be BRCA1 positive, but they didn't turn out to have it. That's actually very important. If you have someone in your family, you have strong family risk, and someone in your family is known to be BRCA positive, and you do not have that particular mutation, you do not have the risk that's in your family. That means you did not inherit it, and you actually, get that. That's one of the huge benefits to testing if you think it's in your family. Now, if you are tested and you come from a family that has a lot of breast cancer risk, and the person who had breast cancer doesn't have the gene, then that doesn't put you in the clear. That's probably still some risk that we don't understand. If there's a family that has lots of cancer and we can't explain it by a gene mutation, the gene mutation testing then doesn't clear you. Okay, can you take estrogen and progesterone replacement after menopause if your breast cancer is hormone negative? And the answer to that is yes. I would always ask someone if what's the reason for taking it and how much benefit that's going to gain, how much you would gain. So I think that's important. Anyway, let's see, more questions here. Oops, wait a second. I had a recent mammogram, and someone who's in the wisdom study, I had a recent mammogram, and do you need my results? And the answer is yes. Please contact the team and tell them the location and date, and they'll request your results. Let's see. Let's see what other questions are. I think
it might have gone to them all.
Okay, if you already have an appointment scheduled in early June and your facility is opening up then, hopefully that appointment would be honored. I think that one of the things that's going to happen is that people are going to, I think that the imaging facilities will probably do extended hours to help with the backlog. One of the things that we really felt was important was to, one of the things that we really felt was important was to tell people to just, not to have it be so that it's all rescheduled, because that way it's so we didn't make it so difficult. It's okay, you don't have to make up for it, and you can just basically wait the 3 months and kind of restart the clock. I think that's one of the ways in which you can help adjust, if that makes sense. Okay, so I really, it's a little hard sometimes when you're, I think it's a little hard when you are on the Zoom, and I can't really tell. I can't see anybody because our video for some reason isn't working. Wow, so it looks like I can see we have 111 participants, so I'd love to get some feedback from you. And we'll send around a, we'll send around a doodle poll. Again, what I would love to be able to, do is, again, ask everybody who's in the wisdom study to please keep in touch with us. If you don't keep in touch with us, we can't possibly follow up and get the results of the study. So for all of this work, we want to really make sure that we get the right answer out of it. So we really need you. We truly need you to participate. That's the most important thing, if you can do that. So that would be great. And I would also say, again, for anybody you know who doesn't have cancer, please ask them to join the wisdom study. Again, if you actually ask people to join the study, if each one of you found 3 to 5 people to join the study, imagine what might happen if everybody who's currently in the wisdom study asked 3 people to join the study. We would actually, well, we don't want to be like the coronavirus thing. Anyway, thanks everybody. Again, someone said, what are the ages again? Anyone from 40 to 74. Anyone in the United States can join. Thanks so much for joining, and we really appreciate your participation.